Hello, everyone. Welcome to Getting Parents to Yes, Vaccine Conversations that Work for Providers and Parents, featuring pediatrician Dr. Sharon Humiston, pediatrician Dr. Nathan Boonstra, and family physician Dr. Margot Savoy. This webinar will focus on strategies to improve vaccine recommendations and conversations with patients and their parents. Before we get started, we wanted to review a few housekeeping items. As a reminder, there is no dial-in number associated with this webinar, and all participants should access audio via computer or internet mode. Please ensure that your speakers are on and connected. All participants will also be kept on a mute mode in order to reduce background noise. As such, please communicate any questions by writing them in the chat box in the corner of the webinar screen. Please be sure that when submitting a question, you direct it to the webinar staff by selecting this option on the drop-down menu of the chat box. If you have issues in accessing the presentation, it may be due to a slow internet connection. Please close all of your other open applications to maximize available bandwidth. If you are having problems with the audio or experience an echo, it may be due to duplicate open webinar windows. Please close all of your windows and reconnect to the webinar. If you continue to experience these or any other issues, please feel free to email us at niamwebinars@porternovelli.com. Thank you for your patience. At this time, I would like to introduce our moderator, Dr. Sharon Humiston.
Thank you, and thank you all for joining us today. We have 670 phone lines enrolled, so that's pretty exciting. We're going to talk today about the presumptive method of introducing immunizations. I think a lot of you have heard about that, but we're going to go into some depth. We're going to make use of a method. We're going to talk about making use of a method to help vaccine-resistant parents choose vaccination, and we're going to plan a response to parents who do decide to delay or decline a vaccine that leaves that relationship between the provider and the parent intact. That's pretty important. So again, my name is Sharon Humiston. I'm a pediatrician at Children's Mercy in Kansas City, and I'm going to have each of the other panelists introduce themselves. Nate?
Yeah, my name is Nathan Boonstra. I'm a general pediatrician here at Blank Children's Hospital in Des Moines, Iowa. I've had a special interest in communicating with parents about vaccines, and particularly about finding out about where parents get information and making sure that they have good information when it comes to online sources and social media. And you can find me at the locations there on your screen.
I love that you consider yourself a geek. All right, Margot?
Lifelong.
Hi, good afternoon, everyone. My name is Margot Savoy. I am the medical director for the Department of Family and Community Medicine at Christiana Care Health System, which is located in Wilmington, Delaware. And I also have the pleasure of being the American Academy of Family Physicians liaison to the ACIP. My interest in immunization spreads both from seeing patients in the office all the way out to a really dorky love of policy and being able to figure out how to make it easiest for us to apply some of the recommendations and the guidelines that are put out for us to take care of. So I'm really looking forward to having this conversation today.
Great. Here is the sole disclosure for today. I also want to thank CDC for their support of my participation through a grant to the Academic Pediatric Association. Today is more of a radio show than the typical slide presentation, and so if you don't see slides advancing like you would in a normal show, that's because we want you to listen and think rather than just look at what's on the screen. So with that said, let's jump into the first topic, making effective recommendations. Okay, I'm going to open this up to our panelists. Why do you use a presumptive style when recommending vaccinations to parents, and what exactly do we mean by a presumptive style?
Well, I think first I'll talk a little bit about what we mean by presumptive. The name presumptive style is, I almost call it a bit of a misnomer. It certainly gives the impression of when you presume that there's some level of arrogance, and that's really not what we mean when we talk about it.
It sounds kind of paternalistic, but
it really does.
Yeah. But what do you when we say it, what do you feel like it really means?
Sure. So it was a term that was chosen for one particular study where we talk about, and the opposite of presumptive in this study was participatory. So it's kind of nice. You got two P words that you can remember, presumptive versus participatory. When we talk about participatory, I'll talk about that first actually. That's kind of the method of going in and telling a family what vaccines are available, and then kind of leaving it up to them to pick or choose which ones to get, and making it more of, well, this is the vaccines that we normally give. What do you think about them? And let's talk about it. Which in some ways I think has some appeal for some people, because we want to make sure that parents, of course, are feeling empowered and that they're making decisions for their child. But on the other hand, we are medical providers, and it is our job to give a recommendation. So the presumptive style means that we give a strong recommendation and say something on the order of, these are the vaccines that your child is due for today and which I strongly recommend. I would like to protect your child against disease X, Y, and Z with these vaccines. Do you have any questions about that? And so it is more giving a strong, straightforward recommendation than opening up to options, which is not to say that it downplays discussion or questions. We want to make sure that the families have the questions answered, and we talked a little bit about that later on. But it is making sure that your recommendation is straightforward.
So the presumption
when I think about the presumptive style, like the word itself, sometimes that word does bother people. Sometimes I'll swap it out for anticipatory. So thinking that you're just anticipating that the parents and the patient are going to say yes, and so you're giving them their recommendation, anticipating a yes, but being willing to have a conversation if it turns out that there's a hesitancy or a no.
So it's like the presumption is that you want to hear that you came to the doctor's office because you want my expert opinion, and the other presumption is that we value the same thing, the health of your child.
Exactly.
Yeah, I think that's a way of looking at it, and that is true that with every parent that we see, we all want that child to be healthy. And so by making that clear that this is the way that you think that is the best way to keep that child healthy, you're making sure to do your duty of giving your medical recommendation. Even if the parent ultimately decides against it, you're still making that clear.
Do you do it in your office? Does it work in your office?
You know, I think it really does, and I often will bring up, one of my special areas of interest and advocacy is for HPV vaccine in particular. So I think of it a lot when I think about that vaccination, because then we get into the whole recommending the HPV vaccine in the same way and making a strong recommendation as we do for other vaccines. I find it very effective for the HPV vaccine when I make that recommendation and make it clear from the outset that I think it's a very good idea, that I think it's medically important. Obviously, it doesn't work all the time, but I do think it makes an impression on parents.
Margot, anything you want to add to this?
I agree. I mean, most of the time when I have conversations with parents about vaccines, but then honestly just treatments in general, I just sort of start with the presumption that they came in because they want to hear what my recommendation is. But then ultimately the decision is theirs to be made, and so that we're working together. And I do think that they're going to be participating to some extent in that conversation, but really that they're there to hear sort of my perception, my 2 cents on it, and what I would recommend they do. And I think that we're really doing our parents a disservice when we sort of hem and haw around making that strong recommendation for the things we believe in because we fear that they might push back or have a resistance.
I know the 3 of us have talked about sometimes doctors overestimate how much resistance they're going to get. I know there was that study down in Texas where they compared how much resistance, well, that was specifically HPV again and flu vaccine, and comparing how much resistance doctors thought they were going to get about those vaccines compared to what parents actually felt. There was a huge discrepancy between the two. Much more, I think that most of us get it, that parents are going to accept polio vaccine. Yeah.
I love that study. I think that really speaks to how much we can do as providers, because we go into a visit, and all of us do. We have thoughts and even our own personal biases and stuff, and things that we might think anticipate an outcome from a visit. But the reality is, when it comes to immunizations, certainly there are parents who have questions, who are hesitant, who are even resistant, but there is a lot of most of our parents want to immunize, and a lot of our parents who are hesitant really just want to hear from the doctor. And if the doctor is making a recommendation, that has a big impact. You talk about that study that looked at, I'm going to mess up the language here, but like doctor perception of parent perception of vaccines is discrepant from the actual parent perception of vaccines. That's true. And then there's also all the data that points to that it very much is, in parents' minds, the physician or the provider's recommendation that is one of the biggest motivating factors in whether or not they choose to immunize their child. Those things together, I think we can keep it in our minds that yes, we're going to come into situations sometimes where it's where vaccines, where there's hesitancy, but we should go in to see our patients with the idea that yes, they probably want to immunize, they probably respect my opinion, and I should give it in the most straightforward way that I can.
I know that you both
I know
train.
that pediatricians in general are kind of a bit particular about making sure that the work that they do are evidence-based or based in some kind of evidence. I know for family physicians, it's a really big deal to know that when we're sort of deciding to change our practice, that we're doing it based on something that we know has been studied, or at least someone's tried to study it. Do you know if there's been studies around the presumptive approach being sort of actually evidence-based as opposed to just our Gestalt feeling about it?
We've talked about the Noel Brewer study where he looked, again, this was HPV vaccination, and in that study, a randomized controlled trial, or it couldn't be controlled, it was a randomized trial, they did find a difference, and that the presumptive approach did work better. Now, I think one of the things Nathan said about it's not 100%, nothing's 100%, and so we have to go in with confidence and the same, just as much as in emergency medicine, the vaccine that we give out the most, of course, is tetanus vaccine, and nobody ever refuses it because I'm going in saying, and here's what we're going to do next. Like, this isn't a discussion. This is what we're going to do next. And I think that same level with HPV vaccine is important. Doug Opel or Doug Opel, I've heard it pronounced different ways, up in Seattle, has also shown that the presumptive method worked better, but not in every study. And so, again, I think that this is one of those things, it brings up for me this great slide that Margot, you shared with us, that you need more than one thing in your medical toolbox, that this is an art, not, we don't have artificial intelligence doing medicine yet. And I think it's partly because of this toolbox thing. So you want to talk about this slide for a sec, Margo?
Sure. I mean, so the way I think about it from a primary care perspective is that, everybody's forever wanting to give me a toolkit. And sometimes we make jokes about it because it seems like everybody thinks there needs to be some new toolkit. But the truth of the matter is that many of the things that people want us to learn how to do require me to learn a new skill or a new way to approach something in ways that I didn't before. And so that if I, think about presumptive format that we've been talking about for the last few minutes, it's a really great tool, and it's a great way to sort of open a conversation. But like you've mentioned already, it may not work in every patient. Sometimes if, all you have is a hammer, everything looks like a nail. And if you keep sort of using that same tool over and over again and it's not being effective, you don't have other things to sort of lean back on, it tends to diminish your ability to move forward with that patient. And so I like thinking about sort of my vaccine toolkit as being not unlike my general recommendation toolkit. So the things that I talk to patients about, weight loss and diet and all the other prevention stuff, is not unlike what I use for vaccines. So things like making sure that I can really adequately pull motivational interviewing tools So things that help me realize how confident they are, how ready they are to make a change, what I could do to help move them towards confidence. Making a strong recommendation we've talked about many times already, and we will continue to talk about, because if people only leave with one idea in their head, the idea that your recommendation matters and the strength of your recommendation really makes a difference, and that what you think is a strong recommendation is probably sounding much weaker than you realize it. So be strong and be bold about what you recommend. But then also things like having supportive patient education for the parents who need to take something home because they're not ready to decide today, or having a reminder system that both reminds you that maybe they decided to opt out this week, but the next time they come back you want to ask them about it more, or they actually did agree to get the vaccine and you just need to remind them when to come back, because sometimes it's not their choosing to not get the vaccine, but they just forgot because life gets busy. And so having a whole kit of tools available to you in your practice, I think, are really important ways of moving forward in how we sort of deliver vaccines and support our parents in making the best decisions for their kids.
Do you find with residents, so, okay, I saw Hib disease, so it's easy for me to talk about the importance of Hib. I didn't see polio. I'm young enough to have had polio not be a big issue in my lifetime, but certainly pneumococcal disease. Do you think that residents today, like now, they haven't even seen chickenpox, most of them. Do you think that it's different for residents and young healthcare providers to talk with confidence about vaccines the way older healthcare providers do?
I am fortunate to be able to teach medical students and residents specifically about vaccinations. And one of the things that I impress upon them is to start, even though they won't in the hospital most likely see a case of measles, depending on where they are, of course, or some of these more rare diseases, they will see some vaccine-preventable diseases. They'll certainly see influenza. They'll see influenza in the PICU. They might see chickenpox. They might see, certainly even if they don't necessarily see pneumococcal disease, they'll see pneumococcal disease, but even if they don't see a specific case of vaccine-preventable invasive pneumococcal disease, they will see some cases of meningitis. They will see some and know of what it is like and be able to describe it, even if it's not from that particular bacteria. So those stories, I think, are worth accumulating, and I impress upon them to keep some measure of either a diary or
That's
something online, not blog about it or anything, but just that for your own personal reference and can go back to and describe to families later. So that's something that I think they can do. But I do think that the research does seem to indicate that sometimes just because of the fading of some of these more rare diseases in the setting of widespread immunization, that it does make newer physicians, they may not necessarily have the level of emphasis that we have. I'm kind of in the middle, I suppose, if I want to describe myself in terms of where I am in my training. I have great emphasis and enthusiasm for recommending vaccines, of course, but some things I've seen, some things I haven't seen. So some of that requires a lot of training, and so when we have the opportunity to teach about vaccine preventable diseases, to make sure that we do so and make sure that they have a good grasp of what some of these diseases that they don't see, what they can do. Whooping cough is another great example that most I think physicians will see. We'll see whooping cough is common enough. A lot of residents are going to see whooping cough at some point. I saw whooping cough in infants and young infants that put them in the hospital in residency, and that's probably not going to change. So that's a good example that they can draw on.
Okay. So two things. So one, actually I find that my residents at least, don't seem to have too much trouble being able to relate the idea that they haven't seen it yet, but they're counseling somebody on it. There's lots of things that we have to counsel people on before you've had a chance to actually take care of someone with that problem. But what I have noticed is that younger parents think that certain diseases seemed to have gone away, and so that the parents aren't worried about it at all. So that even if you're telling them that there's a concern, they don't know anybody that's ever had that before, and so to them it really doesn't seem real. And there's a really great resource that the CDC put out in combination with a whole bunch of people, but I know AAP and AAFP were both partners called Vaccine Conversations for Parents. And it actually has stories that talk about particular families and their experience with vaccine-preventable diseases. And I use it often in the office for people who really can't understand why I think it's not a great idea to have a chickenpox party anymore. And I can give them the story and sort of share it with them. And so you don't necessarily have to have experienced it in order to be able to sort of share a story and help people understand the importance of it. But that's available for free on the CDC website.
I love what you're bringing up, and we'll get to resources at the end, but also for me, the Immunization Action Coalition has the Unprotected People's Stories and the website Shots by Shots that has the stories of people who have suffered because of vaccine-preventable diseases. Yeah, I think that that's a great way for parents and for training office staff who, again, the MA in the office, is probably young and didn't have tons of training in this. And so showing those kind of videos and, just the human stories rather than just statistics, I think that's huge.
On the topic, my favorite of that similar kind of resource is the books that are made by Texas Children's Hospital that are called Preventable Disease, The Forgotten Story, and each one of those pages basically will bring tears to your eyes because of how well it's written, photographed, and really makes those stories of loss personal, which needs to be remembered.
Yeah. So that, you have to remember history so you don't repeat it. All right. I'm going to have you move on. What are your other key tips for introducing vaccines? What would be the other key things that you would say are a big deal for you?
So one of the things that I do is try to remember language that puts the idea of prevention and protection in the forefront of the parent's mind. So whenever I talk about immunizations, I talk about them, I use the words, and today I recommend that we immunize and protect your child against these diseases, instead of just saying, just get the shots for these or immunize against these diseases. I want to put that idea in that we're doing something active to protect and prevent disease. So that's something that is worth kind of keeping in your own lexicon, but also trying to, and this is a theme that will come up again later, train your staff to do so as well. And then another one that I'll mention is going back to that HPV. There are techniques that I think a lot of providers have heard about in terms of making sure that vaccination is recommended, and this is true about all immunizations, recommended the same way as other immunizations. So that same day, same way idea that I recommend this vaccine just as much as I recommend the other vaccines, and not making it a situation where you mentioned the other two perhaps routine vaccines like the meningococcal vaccine and the Tdap, and then often this might be staff, saying your child's recommended to have these vaccines, and then there's this third vaccine, the HPV, that the doctor will talk to you about when they come in the room. That kind of method can really lead to already the idea that one vaccine is not like the others, and lead to more hesitancy on that. If they know that all the vaccines are recommended right up front, if your staff is presenting them that way, I think that can go a long way towards helping you succeed as the provider in then making that strong recommendation.
Margot?
And that brings us to the strong recommendation, which we can't say too many times today for you to really understand how important we think this is, that you give a strong recommendation. And honestly, you can even use the words, I strongly recommend that we give your child his Tdap, his HPV, and his meningitis vaccines today. And honestly, something I learned just as we were preparing for this conversation with you all today was, Nathan actually specifically points out the diseases to prevent against tetanus and pertussis, HPV and meningococcal disease. And I've never really thought about putting the diseases sort of in my strong recommendation before. And that honestly brings it back to the point that we're preventing cancer, we're preventing infection, and these things are truly important. And so giving a strong recommendation is something that, if you haven't heard us say it yet today, you want to give a strong recommendation. So that's something that we really want to make sure that you guys take home. And then also being really targeted about your responses, so that sometimes when we get excited about giving a strong recommendation, we expect the other person to just jump on board immediately and go with us. And every now and again, they may have some questions. They may seem to hesitate or want to ask, and they want to ask some more questions of us. If you go into it, so I give my strong recommendation, and before I even give the other person a chance to think, I launch into a paragraph assuming that they're going to have all this resistance and be, very, very apprehensive about being able to give this disease today or give that particular recommendation their full thought. Honestly, I didn't even give them a chance to ask what was really worrisome to them, and I may introduce a whole lot of things that they weren't even concerned about that I've now added to their worries, which I didn't even mean to do. And so if there's another key point that we could remind you, is just to sort of stop talking. So give your recommendation and let it hang there for a moment. And then if they have a question, you can just simply ask them, is there something that you're concerned about? You seem a little concerned. Is there something that I can help answer? And then just answer the question they ask. So you don't need to give them 50,000 other things that you think they thought they were going to be worried about. Just answer the ones that they're actually concerned about.
I think it's just stop talking. I think that's great advice. The thing about the perceived concerns may be greater than the real concerns of the parent. All right. Well, let's talk now.
It comes up often that we as providers almost arm up when we're going in to talk about certain things that we perceive there's going to be resistance about. And like Nathan, I do a lot of HPV work, and for some reason, we just think that we have to be like total, knight in armor, armored up from head to toe, ready to go into battle to talk about HPV vaccine. And most of the time, the question that I get back from parents when I just sort of stop talking is something simple like, was their arm going to be sore because they've got a baseball game later today? And it has nothing to do with the other things they might have heard about on social media or all the other stuff that people are actually worried about. And so what we're perceiving as being, terrible resistance, often it's really in our own heads. We've sort of built it up a lot bigger than it genuinely is.
It's I have even heard people who work for NCIRD say they went to their pediatrician's office and of course they didn't anticipate refusing a vaccine, but they asked a question, a simple question, and the doctor immediately went to, if you don't want these vaccines, we won't do them. And it was like, no, that's not what I meant at all. All right, I want to move now now we're talking about a parent who really is hesitant. It's not just the one question parent. We're talking about a parent who comes in and launches with, I really have concerns about vaccination, or with a single vaccination. It used to be varicella for a while. I think now it's more frequently influenza or HPV. What tips would you have for parents, for communicating with parents who actually are hesitant?
I'd like to kind of add on to what you were talking about before about the questions and the occasional pushback that you get, which say that study that looked at presumptive versus participatory also looked at what physicians did when there was initial resistance. Found that when questions were answered and that strong recommendation was continued to be given, that uptake, there was a much higher chance that family was going to immunize than if they kind of did what you said and kind of backed off and said, oh, well, we can do these at another time. So one of the things is to answer questions. Don't assume that in a hesitant family that questions, well, actually don't assume that questions mean hesitancy, for one. Questions might genuinely, I want more information, I'm still planning to do this. But if a parent perceives that you then are, because you're answering questions and are kind of not giving as strong of a recommendation, then they may perceive that as, well, I guess the doctor doesn't really feel that strongly about it. Let's not do it. So that's my first thing, is to answer questions as best you can. and to still make that strong recommendation after those questions are answered.
Mm-hmm. I've heard of there's a model that was developed by Vax Northwest, which is an organization up in the Seattle area, called the Ask, Acknowledge, Advise model. Have you heard of this? What do you think of it? Either of you?
I mean, so we use something very similar in our practice. It's not unlike what we call the 5 A's that we use for things like tobacco cessation and things like that. But it sort of starts with the premise up front that you truly, as the provider, are a trusted source of information, that the patient already trusts you, that they're coming to you because they want your advice, and they have questions. So it's not that they're just dismissing the things that you're saying, but that they have a few questions that they want you to answer. That's why they're coming to you and they're having that conversation with you. So the fact that they're willing to ask you a question is not necessarily a sign of something bad. It's often a sign of something good, that they trust you to give them the best advice and the information. And so the way that you want to start off is by truly respecting the fact that they're asking you a question, that they feel comfortable to ask. And so if they seem nervous that they're not yet asking the question, really just calling it what it is. So you seem nervous, what's concerning you? I mean, and honestly, it's a very straightforward thing to do, but sometimes people need permission to ask that question. It makes them a little uncomfortable to feel like they might be challenging the doctor. And so you're literally giving them the permission.
It's like it's worse if they don't ask the question.
Correct. Because then they may be choosing to do something that they're worried about, and you could have easily alleviated some of their fear. And so you're just asking them what's concerning them. But the key to this part is much similar to what we were talking about earlier, and then stop talking. So if I'm going to ask you what's concerning you, I can't keep talking through it and never actually give you a chance to answer. Silence is sometimes a place where we got to get comfortable as providers. And so don't interrupt them. Let them speak and tell you what it is they're worried about or what they're concerned about. And even if they're saying things that you know are not true, you don't have to interrupt them. You can let them finish what they have to say. You can make notes if you need to make notes. And then before you jump in to just automatically telling them why all the things they just told you are wrong or why you don't agree or why they're missed, you want to just acknowledge that you truly appreciate the fact that they took the time to talk to you, that they asked the questions, and that they are really interested in the welfare of their child. So sometimes we get caught up in this us versus them mentality by accident, and we think that we care the most about their children because we know what's right as the doctor. And the truth of the matter is that they love their child too, and that they're trying to make decisions on things that they have incomplete information about. They don't always have the complete answer for what they need to feel comfortable. And so if you're operating from a presumption that they love their child too, and that they're trying to do what they think is best, it makes it much easier for you to acknowledge that their concerns are real, even if you disagree with what the content of them are. And so something like, I hear that you're worried about A, B, C, and D. This is what I heard you say. And then give your advice again. I don't want you to do something that makes you nervous. I wouldn't ever ask you to do something I wouldn't do for my own family. Do you mind if I tell you about what I know about the concerns that you've raised? So that you've asked permission to be able to help educate them, so that you're literally not jumping into pointing the blame and calling them, silly in not so many words, but that you're genuinely open to having a conversation. And I honestly think that goes a long way. So asking, acknowledging, and then advising.
And you're bringing up in the toolbox slide, you were, among the many tools that you had, one of them was motivational interviewing, and this fits right in with that. And I have to admit that sometimes I have a knee-jerk reaction when a parent says, oh, I've been doing my research on the internet, and immediately the hair on the back of my neck goes up, and I'm resistant before the next word comes out of their mouth. And so I think that one of the things that you said about actually listening, it sounds so obvious, but sometimes it's hard because my knee-jerk, and I have something go on in me about, I don't have time for this.
Absolutely. Honestly, I get it. We have very short times with parents. One thing where we get lucky, especially when we're talking about children and teen vaccines, is that we often have the opportunity to see them back again in the same year. So it's not, sometimes in adults they go away for a long time and you don't really get to see them again for another year. But in teens and also often in children, you're going to see them again before the year is over. So even if you're just starting the conversation now and you know that you're going to have a chance to continue it later, you don't have to feel quite so pressured to make them sort of come to your side and agree with everything that you're saying today. You're just giving them advice and helping them move forward. If you try to shove me through making my decision, I'm way more likely to go from being just a little bit hesitant to being truly resistant than if you're sort of helping me to understand how I'm going to come to make this decision so that I can be comfortable with it. And so just really thinking about sort of those key messages that you need to get across, but also addressing their key concerns, and then tuning into their communication style, because a lot of times I see providers waste time using the wrong style on the wrong patient. So if I show up and I've already done my internet research and I'm spouting numbers at you about statistics of things I'm worried about, don't spend all afternoon telling me stories about your grandkids, whatever. You get to the numbers, because I'm a person who really values numbers and details, and that's what I want to hear about. I want to hear about the study. So you start there. If I'm telling you about I'm just afraid because I thought that, I remembered the story about my grandma when she was little, then you might start with stories with me. So really honing in on the style of that particular patient or family and starting there might actually shorten some of the time that you're spending in that conversation.
That's a great tip. I mean, the listening makes it so that you can match the style, but you have to listen first.
Absolutely. Nathan also had the case approach, which I think is similar to ask, acknowledge, and advise, but it's a little bit different for people who maybe need another way of approaching it.
Yeah, I think it incorporates elements. So this was one that I've had the opportunity to learn about, and this is from, I believe this was developed by Allison Singer from Autism Science Foundation, and I think it's it's an acronym that incorporates a lot of what we were just talking about with the Ask, Acknowledge, Advise. So it's the acronym is CASE, C-A-S-E. So the first one's corroborate, which is basically making a statement that shows that you understand where the parent is coming from. I understand
Instead of starting with, oh, you can't trust what you read on the internet, starting with corroborate.
Well, some statements would be something like, I completely understand if you've read these ingredients, and I can see why you would find those off-putting and be wondering about the facts about this. I would be exactly the same if I were in your situation. Or, if I understand this, you had this experience or you heard about this experience, I can see why that troubles you. I would feel the same way. And then the next is about me, which doesn't mean like you just go tell all about yourself. It means you kind of relate what you've done on this particular subject, or why this is really an interest of yours, so that the parent knows that you actually have a background in this. And so you might say something like, yes, I've recently been to a conference and learned about this, or I was interested in this myself when I had my own children and wanted to do more research about vaccines, or when I became a physician or whatnot, or point to a specific things that you've read. I actually often relate, I was really interested about this, so I read these, what we would consider for lack of a better term, anti-vaccine books or websites that I went to, and I read a lot about them, and I relate that to parents.
Somebody told me that the about me part for him, again, we keep talking about HPV, but he said, I know a lot about this because a friend of mine died of an HPV-related cancer. And so the about me was, I've done a lot of reading about this because of my personal circumstances. So there's different, that was a little bit of a different take on about me, but.
Yeah, I think that's a good thing.
Just to be clear, you're not telling people to make up stories. So if you don't have a friend or a family member who died from something, do not make up the story, because the parents can tell.
No. No. This guy's college roommate died of oropharyngeal cancer.
Yeah. I have a friend also he's a survivor of HPV-associated oropharyngeal cancer too. But that kind of, lends itself also to the last letter that I'll get to in a sec. The science is basically then your chance to talk about, in limited measure, the science that you know of that addresses their concerns. So if it's too many too soon kind of hesitancy, you might point to the study. The author's escaping me at the moment, but there was a study that looked at the number of vaccines and neurodevelopmental outcomes 7 to 10 years later, where they looked at parents who got the vaccines on time, the parents that got the vaccines spaced out, and parents that got reduced number of vaccines for their children, and looked at 42 different neurodevelopmental outcomes 10 years later and didn't find any difference between them. But you're going to say that kind of more briefly probably than I did, or you might actually show them a...
Well, I think you're bringing up a good point, though, that you wouldn't use the language neurodevelopmental outcome. Yeah, but so you have to translate, too. Yeah.
And then the E is for explain/advise, but also that E stands for a little bit of emotion, because the research shows that although we do need all those tools in our toolbox, science alone and facts alone don't necessarily overcome fear. And there's a little bit of evidence that parents knowing the potential bad outcomes of a disease, the better they know that, the more real that is to them, the more likely they are to be immunized, which is not to say that I think that we need to use fear factor here, but we do want to be realistic in making sure that the parents know about these outcomes and that it is at least somewhat realistic, like personal somewhat. So to say, I have seen, so in my case, I have a friend who has had to have surgery and survive HPV cancer, or I have I know somebody who died of HPV cancer, or to say, I remember in your case, talking about Hib disease, and I wouldn't want this to happen to your child. That's why I think it's a great idea for your child to be immunized today. So that's the 4 points of that particular method. That, if nothing else, it's a nice acronym you can remember in your mind, and try to go through those when having a conversation.
Mm-hmm, mm-hmm. We talked before about the art of medicine and matching parents so that you know whether you use storytelling or statistics. Anything else either of you want to say about this concept?
And I do think that depending on the family that you're working with, focusing on sort of that human story side rather than focusing on statistics is actually often helpful, and we tend as scientists to go straight to the numbers, and for a lot of people going to the numbers isn't necessarily the most helpful thing. There's some other tips that we're going to get to in a little bit, but I think the other thing that's important is that you don't keep repeating the myth or the thing that you've heard but that they maybe didn't even mention, because you're not trying to make people comfortable with the idea that the thing that is not true is actually true by having them hear it so often that they start to not be able to tell whether it's true or not. And so a lot of times you're addressing directly what they're asking or what they're concerned about without repeating the part that's untrue, just focusing on the part that is true, even in your storytelling. I think that makes a difference.
The thing about MMR causing autism, people have heard it so often that they think it must be true. They haven't looked into the science of it at all. They don't know the statistics of it at all. They've just heard it so often. Well, if I've heard it a million times, it must be true. So avoid saying it. Yep. I had put up the list of additional tips. As you guys want to comment on any of these that you think are particularly important?
I looking at it, one of the things I want to mention is kind of number 7 there, to be inclusive. I wouldn't phrase it. Certainly there are groups out there that are anti-vaccine, but when you're talking about the parent that you're talking to, they're extremely good, that they're not necessarily against vaccines, period, that they're against they have certain concerns about them. And maybe those concerns, maybe what will ultimately get a parent to think that a vaccine is okay is not necessarily realistic, but all of the parents, most likely, unless it's a very rare parent that's truly against all vaccines. Not the difference between parents in my clinic that I talk to and people in groups that I encounter online is a wide gulf. So I don't like to think of any parent, even if they're very, very hesitant in my clinic as anti-vaccine. I like to think of them as continuing to learn. And some of them may not learn enough that they ultimately immunize, or they may have other things, other barriers that I'm not going to be able to overcome. But one of the things I think that's so difficult to study, because when we look at the research, there's not, we can say, well, we know that presumptive approach helps a little bit. We know that when questions are answered and we continue to give a good recommendation, that might help a little bit. That it may help a little bit to make sure that parents are aware of the bad outcomes of these diseases and the complications, the sequelae. These things will help a little bit, but there's no study that shows like this is the thing that helps like nearly 100% of the time. There is not that. And one of the things that's so hard to study is the relationship between the parent and the family and the physician, the provider. That's more intangible. That developing that good relationship and having those conversations and adapting, using the things that Dr. Savoy is talking about, that toolkit of things that are going to be different for every approach, and trying to know your family is something that's hard to study, but something that can be effective. If they're continuing to come to you as a physician, as a provider, they're doing it for a reason. They respect they respect your opinion, probably on most things. And maybe in the area of immunizations, it's hard to get past some barrier that's there, but that's not to say that it's not worth continuing to have that conversation and see what movement you can have.
I think that's a really important point, especially when you're dealing with the parents who do ultimately decide that they want to delay or decline, that what you don't want to do is sort of burn down the whole relationship, so that you spent this time building a relationship with this family, and that there are ways that you could end that conversation that would effectively end that trust and end that relationship with the family. And there are ways that you could sort of live the fight another day. And I do think that it's important for us to sort of, I happen to be of the live the fight another day approach, but I just think it's important to give real thought to, before we sort of automatically fire people or automatically ask them to leave our practice, sort of thinking about if there's ways to manage that decision to delay or to decline altogether, but still have a relationship with that family and with that child.
Okay, so what do you say to a parent who's declining or delaying in order to keep that door open? How do you manage that?
I mean, for me, I actually get pretty lucky that I don't get nearly as much pushback as it sounds like some of my colleagues across the country get about vaccines. I'm not sure if it's just the population that I have, or that I am just such a great explainer of vaccines that they just all give in. I'm not really sure. I like to believe it's the latter, like, but it's probably more likely
sometimes
the earlier.
Parents pick you because they know that you're pro-prevention, and so that they may not be vaccine hesitant because they've picked you because they know that you're all about prevention.
Well, and for me, I tend to be a pretty straight shooter about how I feel about things and what I believe in and what I don't. And so I will tell them up front that I really think it's important, and that, I wouldn't tell them to do anything that I honestly wouldn't ask my family to do, and that I wouldn't do to take care of my own family. And in my case, it's particularly interesting, and it's why I say that you can have these conversations even if you don't experience it. I don't personally have children, but I can tell you that if I had a kid, these are things I would give my kid. But what I do have are lots of nieces and nephews that I've adopted over time, and I've told all of their parents the same thing, and I'll tell the next patient that comes in the room the same thing, because I really believe it. And so I'm hoping that you'll come along with me and agree. But if you decide not to, I want to leave this conversation with you understanding that I still respect you as a parent, and I know that you love your child and you're trying to do what's best. We just disagree on this particular thing. I'd like to give you some information to take with you, and maybe you'll give it some more thought, and we can talk about it again next time. But know that I'm going to bring it back up the next time, because I love you, and I think it's important for you to know that I think this is important. And so for me, I tend to keep it focused on that.
Do you guys ever have them sign a declination form?
I do. So I use the tool pretty routinely. I think that, so there's the AAP declination form that you can get online. It is, I think, useful for a couple of things. First, just because then you have kind of done your due diligence in covering yourself and making sure that the parent has been fully informed. of why it is dangerous to refuse immunizations. I also think that it makes it so that the parent realizes that you're, again, I mean, hopefully you've already made your strong recommendation. And if I do have a situation, and like Dr. Savoy, I don't have a whole lot of families that refuse, because if anybody Googles their physician, like my name and a vaccine are going to be like right next on Google.
Mm-hmm.
But if I do have a family that's declining one or more, first I make it clear that I still recommend it. I don't want that to mean any uncertain terms. I don't want them to think that they left the office and say, oh, my doctor's fine with it. Well, I do, like Dr. Savoy said, I respect them as a parent. I don't think this decision is a good one, and I can't agree with that. And so I'm going to give that strong recommendation. I'm going to try to keep those lines of communication open so that they can communicate with me at any time about vaccinations. And so I'll use even the electronic medical record allows them to contact me, the one that we use. I can look stuff up for that. Like if they have a specific question or a web page that they read or something, I can address that in reasonable time as they come, as they encounter it. And tell them that we're going to discuss this at every time. That's important to me. And then I think that this form helps drive that home. This is important to me. This is a big deal to me that you're refusing these vaccines. I want to still have a good relationship with your family, but this is important, and I need you to sign this. And I think that that's helpful.
Do you ever?
In our office,
so then
we don't use declination forms in our office. There isn't really a policy from the AAFP one way or the other about it. We don't advise that people decline vaccine, and we don't advise for people to be off schedule. But there isn't a specific form that we would recommend that people use or not use. In our practice, though, what often will happen is that we'll just document the fact that they've decided to decline, and then we add it to their problem list so that it's able for us to remember easily so that it can be brought back up at the next visit.
Okay. What do you guys do about if a parent declines? Do you know in your office, are families ever fired from the office, dismissed?
So, I mean, I think you can tell from our conversations that we don't.
Yeah.
I understand, I've had a lot of really interesting discussions with colleagues on this topic. I think if we talk about controversies with vaccinations, most of the stuff we talk about are not legit controversies, no controversy as to how safe or effective they are. But there is a genuine, at least in the pediatric community, ongoing discussion about families that refuse immunizations. Should some practices dismiss or not? I personally still continue to fall down on the side of I still need to take care of that child regardless of those decisions. And I talked a little bit about how I approach that with families, but that's the conclusion that I've come to.
Mm-hmm. Mm-hmm.
I know I'm similar. So the AAFP doesn't have a policy that supports dismissing kids from practices or families from practices. That being said, I've heard the cases. So this is one of those times where you're sort of using those same skills that you're using with the parents with your colleagues, and actually being open to hearing their perspective and where they're coming from. So where I stand is very similar to Nathan. I just really don't dismiss people very easily from my practice for most things, because normally the people who you want to dismiss are the ones who need you the most. But what I do understand is what the concern is that my colleagues are raising, which is that you are exposing other people to diseases by not having been vaccinated. That you could walk into the practice and some babies may not have yet been able to be vaccinated, and now they're being exposed to your child with this vaccine preventable disease, and that's really putting their life at risk. And whether or not you think it's appropriate to take that risk on in order to help the child. And so I see the dilemma. I don't know that there's an easy answer.
Mm-hmm. I know AAP came out with a statement about that they don't recommend firing families, but I have heard, so like my pediatrician, what he did when we first joined the practice was, my children's pediatrician, that he said in the initial letter, here's the schedule that I use, And if you are not going to accept vaccines, it's very likely, like I feel so strongly about vaccines, it's very likely that you are not going to take my advice on other important issues, and so I may not be the right choice for you. So he did it instead of at the back end, he did it at the front end by saying, here's where I stand on this, and I am very passionate about it, so we're going to be set up for having conflict at every visit if you're going to refuse vaccines. I thought that was another approach.
Yeah.
All right,
It's definitely an interesting idea.
A little bit, though, too, is that in general, I feel that because of the kind of misinformation that's out there, because of the emotion that's attached to the topic, vaccines it seems to be different than most topics. I don't feel of the patients in my practice that of the ones that I continue to see that refuse immunizations, that they then don't believe anything that I say. That does not.
Yep. Okay.
Now, my experience. I would like to. I think it's a good chance to. I know we're getting a little late here, but I think this is. I really do want to bring up the idea, though, of regardless of what you choose to do. Making what I call and what others call a culture of immunization in your practice is, I think, one of the most important things you can do to foster good vaccine uptake. And of course, it's multi-pronged, so there's a lot of things that can make a difference. What that means is making sure that your parents know, that your families know how important immunizations is to you and is to the practice. And that can involve talking about it at prenatal visits, talking about vaccines in advance of the time when they're going to get them, so talking about them at the 2-week visit when they're not going to get vaccines until the 2-month visit, making sure that you have literature and visuals in your clinic, in the waiting room, in the exam rooms that express how important immunization is, making sure that your staff is trained on how to address vaccine questions, even if it's the person who's answering the phone, knowing how to direct that question and be able to give their basic script about immunizations. All of those things, and there's probably other things that I'm not thinking about, so that people that choose your practice are already choosing a practice that clearly values immunizations. I think that goes a long way as well.
Mm-hmm. And I think it really helps. Like, I know we're about to flip through the resources. This is one of those times where you don't want to keep the resources to yourself. So even though we're sharing them to you directly as provider to provider, honestly, these are the sorts of things that you want your staff to know that, hey, you know what, if you come up on a question and you're not sure, here's where you might want to direct the parents to, or here's where you might want to check out yourself. Because often I will find that patients will have asked me questions, but then when the nurse goes in to give the vaccine, they come up with another question, and I've already moved on to the next office, and so everyone's a little hesitant to come and interrupt me in the next office. But this way, the staff know where they could go grab the resource and give it off to the parent, and it makes it seem like everyone is knowledgeable, which they are, reinforces the idea that everybody's on the same page, but then also provides the parent what they need.
Yeah, that's great. All right, I am going to flip through these really quickly because we are almost out of time. I think most of the folks on this line know about the great resources through CDC. We've talked in this show about Shot by Shot. We didn't mention Someone You Love. It's a full-length movie about the HPV epidemic, which is well worth having everybody in the office watch. More on HPV, I love what used to be called Tips and Time Savers and is now called Talking to Parents About HPV Vaccine. It's just the CDC put together like quick scripts to answer the most common questions for parents. And then other resources other than HPV from CDC, obviously, the schedule and having parents know what to anticipate, like Nathan was saying about having parents know, even from the prenatal visit, what to anticipate. And then if some parents might do better with the parent version of the schedule, which is a little easier to see. and then for special needs. All right, so I think that's it for, oh, and Margot mentioned these. This is more CDC sheets, including this one on the far right, which I think has just recently been updated. If you choose not to vaccinate your child, understand the risks and responsibilities. Well, that's it for time. I don't know if we are allowed to stay on a little longer to take some questions or if we need to get off this line.
We can actually take a couple of questions if you like, and we have a couple of good ones I'd like you guys to answer. If you guys can stay on. We just have a quick question around, this one is actually kind of a question about research, but I'd like you guys to answer it in the context about if you think there is a difference in the amount of time that it takes to make sort of an announcement recommendation versus a participatory recommendation.
This is Sharon, and I'm going to jump in. Yeah, I think, Greg Zimmett up in Indianapolis did a study where he actually tape recorded. Now, again, we're back to HPV, but where he tape recorded providers talking about HPV vaccine, and they're awkward. They don't get to the point. And that's one of the reasons why I love the tips and time saver sheet so much, is because I think by having scripts that you get to the point and you are accurate, and so it's with the introductory thing, it's so much faster to say, we have 3 vaccines that I think are important for you today, this, what questions do you have for me, as opposed to, so tell me how you feel. I mean, just wandering in the wilderness.
Yeah, I think especially when you look at the concept, less is more. Like we want to make sure our parents are informed, but we're not, when we're recommending vaccines, going to wax on at length about everything. If you're making a strong and fairly succinct recommendation in telling what each disease is and that you recommend the vaccines, that does not take a lot of time. Whereas just kind of saying, well, with every patient that you see, we're going to open up to a potentially widespread conversation about vaccinations that could take quite a lot of time. I think sticking with the strong recommendation and the presumptive approach is going to save time overall.
Especially if you can be disciplined to stop talking and stop interrupting your patients and only answer the questions that they're asking you. Again, I'm stunned at how often we interrupt people and how often we answer things that are not at all what they said. So we started off answering their question, and then 3 paragraphs later, we're still talking. And if we cut some of that out, you'll actually save a lot of time.
Okay, great. I have another question for you. Just real quickly, in terms of if you've got a parent that's asking about severe side effects that they've heard of, say very specifically for HPV vaccine, what would you direct them to? Or if you're, for another clinician, if a clinician colleague is asking you where you get information about things like where you get information about side effects of vaccines and things like that, where would you point them to?
For HPV, we get really lucky because we actually have a national HPV roundtable that's got an entire clearinghouse of resources that are available. And so one easy place to direct particularly colleagues to is that clearinghouse. I can't think of a question that you might have about HPV that doesn't show up in that clearinghouse somewhere on their website. And so that's one place that I would send folks to. But then you know that with any vaccine, they have to report a lot of the adverse events through theirs. And so you can often find some of the reports in the MMWR about things. Fortunately for HPV, there have been so few adverse events in general and no real severe adverse events, so that we don't really have huge piles of data to give them, because most of the data shows that it's actually a really safe vaccine that doesn't have these concerns that folks are worried about.
So most of the side effects information would be on the actual VIS itself then?
Yes, the real deal is on the VIS. Yep.
Okay, I have another, I'm going to stay on HPV for a second. We have another quick question about that, which is when you have teen girls, which is outside of the recommended age range of 11 to 12, but when you have teen girls themselves in the office, do you ever talk to them without their parents present about the vaccine?
So my approach...
Yeah, that's what they want to know. What's your approach?
Yeah, I always talk to, so I'm presenting these vaccines at 11 or 12 the overwhelming majority of the time. So in that case, there's definitely a parent in the room, and I'm talking to them. My approach in general with physicals is to talk to the child and let the parent overhear me, even when they're fairly young. So I'm talking to the adolescent and telling them about the immunizations that I'm recommending that they get, and then finding out whether the child or the parent have any questions. If it's an older teen, certainly there may be situations where a teen talks to you about the vaccine. Parent present, I always do with all of my teenage visits sometime where I talk to the patient without the family present, because I want to make sure if there's any concerns that the patient doesn't want to bring up, that they can. So if they want to talk about the HPV vaccine and they haven't gotten it already, I guess that would be a situation where you might do that. But for the most part, I don't have those situations, because most of my kids are immunized at 11 or 12, and that's a decision with the family.
All right.
Sometimes I will find that if you have older teens who weren't able to get it at a younger age, I will reopen the conversation, though, so that every now and again I've had people who I saw when they were in their younger age, now they've gotten old enough to go off to college, they're now 17, 18 years old. I will often re-ask them again, are they sure that they still don't want to have it? And sometimes the answer is still no, because in their family, for whatever reason, that's not something that they would want to do. But actually, I've had quite a few folks who, they didn't get it because their parent didn't want them to have it, but now that they're quote-unquote an adult, they want to make their own decision and are ready to have it done, and so in that case, they would.
Yeah.
All right, I'm going to switch gears for you guys real quick and ask you a question about, does your approach change at all when you have, so we're talking about infant and young childhood vaccines here, for children who have, say, special needs or developmental delays? Does your approach to recommending vaccinations change at all for them?
I don't know that my approach changes per se. I feel like for the most part, children with disabilities as much or more than any other child. So I don't know that unless the family has specific concerns unique to that situation, that I have much of a difference in approach. If they have questions about it and feel like because of the child's condition that they shouldn't immunize, then I'm going to have the approach of, well, and of course it depends on what we're talking about, but if it's the case of somebody who's very premature or who has pulmonary issues or something, I would take the approach of, well, really, I'm more worried about your child than other children, and think it's even more important that they get immunized on time.
My approach doesn't really change much either. I tend to be one who doesn't rely on my own memory for vaccines anyway, and so I just tend to pull out the schedule at the time with the parent sitting there to figure out and double check what we think they need versus what they've already had. And so the one thing that sometimes may happen that doesn't tend to happen with others is that often they have that separate table, and so I'll show them the table and where I'm coming up with why why do they need the vaccine that their maybe older sibling didn't need, that sort of thing, if it comes up and there's a difference. But often my general approach to them doesn't change at all.
Okay, great. I have one final question for you guys, and that is, what suggestions do you have about countering myths that may have been perpetuated by other physicians or alternative healthcare providers in the community? This one participant was asking, there was a lot of chiropractors and homeopaths in their community that are strongly discouraging vaccination, as well as MDs recommending quote-unquote alternate schedules. And they wanted to know if you have any suggestions for talking to families that have heard that information. What would you recommend?
So for me, I try to stay out of fights between us versus them because I never win. So typically speaking, if somebody shows up and they want to know about their alternative medicine, fill in the blank person, they've already pretty much decided that they agree with that person, which is why they're choosing to go to them, usually at an out-of-pocket price, different than what they're coming to see me. And so my conversation becomes less about arguing with them about the fact that the other person is wrong and asking them more to explain to me where they're coming from and what it is that they were looking for from that person. So what is it that you're actually trying to get at? So are you trying to do this delayed approach because you're concerned that it's too many vaccines at once? And what information did they share with you that made you feel like that was appropriate, and really having them do the legwork to figure out whether or not what they heard was valid or not valid? Because I find that having them walk through how they made their decision and whether their decision was truly an educated one or one that was based on misinformation or false information often helps them to reach the conclusion that I think that I would have reached anyway, which was that probably the information you're getting is not as accurate as you would like it to be. But when I just sort of start off with, I think that particular doctor is a quack, it never goes well, and I don't tend to win any point.
I think that sounds like a similar approach. I mean, really, it's still getting down to the root of what are the concerns that they have. But the question there is there hesitancy because they believe this particular alternative medicine practitioner more than they believe you? And that's difficult to really sort through. That's a more fundamental level. I tend to be, when it does come in general to that kind of question, I am also fairly straightforward with my recommendation, which is that I don't recommend chiropractic care for children, and I'll be happy to spend time again with that, very similar to vaccination. Well, why not? Well, I can tell you a little bit about what I've done to read about this. I can tell you a little bit about what I know about what studies are out there that have looked at it, or what the plausibility is, or what science or lack thereof there is for this particular modality that they're doing. So that's another kind of conversation. But when it comes specifically to the vaccinations, it's a time when I think, again, opening up to access to you to say, okay, they told you this, or they gave you this link or this thing. Let me look specifically at this concern. Even if you don't write immediately in that visit, you can't certainly address every single myth or every alleged study or something that a parent might bring to you. You might need a little time to look up and figure that out. It takes some time, and that's, I think, one of the things that's difficult when we talk about these conversations is finding and making that time. But I really do think it's worth it with these families.
All right, well, that was the last of our questions, and I just would like to thank all three of our wonderful guest speakers today, and we really appreciate everyone's time and staying on for an additional 15 minutes. We will be posting this webinar as well as releasing the slides to everyone. Thank you for your time and appreciate you being with us today.
Thank you very much. Bye-bye.